name's Alex.
I'm Tenny.
And I'm Daniel. Our device is an artificial pharynx replacement. Just as a warning, there is a graphic image on the next slide.
Appreciate it.
So every year, about 90,000 people are diagnosed with nasopharyngeal cancer. The primary option for treatment is chemotherapy. However, this doesn't always work. As a last resort, they usually have to undergo an invasive procedure, a total pharyngeal replacement. As you can see from this diagram, this involves slicing open the entirety of the neck, and then they use a portion of the intestine or of the chest muscle as a graft for the pharynx. This surgery has a 5-year survival rate of about 38%, which is very low, and this is due to the materials failing pretty rapidly, and many people have to get additional surgeries, which increases more risk, in addition to the additional wound site that's created by the autograft. So our need is for a pharynx replacement implant that provides prolonged support and function in order to prevent these additional surgeries to extend the lifespan of the patient.
So for our proposed device, it will consist of a polymer scaffold, which will be PET, or as it's known by its brand name, Dacron. We selected PET because it's a non-degradable polymer that's used in many cardiovascular applications. And we're also going to use wire mesh to be inserted to prevent the collapsing of the scaffold and to prevent stenosis. And then the thin sheet of collagen will be grown on both the outside and inside of the scaffold to provide properties such as elasticity and tensile strength. And then on the outside surface of the scaffold, it will be coated with hyaluronic acid, which will serve as an anti-inflammatory drug to combat inflammation inside the patients after surgery. And then lastly, we're planning to use a degradable suture to fix the scaffold into the position of the neck after surgery. And yes.
So there are several benefits to using this implant instead of the traditional surgery. For one of the major ones is there's no more need for a donor site, which on its own is a whole separate surgery and has its own complications and risks associated with it. It would be more successfully integrated with that and avoiding complications like fistula and stricture, in which fistula, there's like a gap between the tissues when it's trying to be implanted or sewn in, or stricture when it swells and constricts the airway. Using this polymer, an artificial material, a tumor would not be able to regrow on the tissue. If you use the donor site and implant another tissue, the tumor could just regrow there. You could custom fit this material to the patient. It has, the adjustable size can change the properties to increase its fatigue resistance. And with it, again, there would be no need for additional surgeries after following, or hopefully without any complications. There are some limitations to this, though, as it is a combination of both a biomaterial and a drug, so it would cost a lot more money and time and FDA approval. It's still a high-risk surgery in that they have to open up your neck, but you wouldn't have that other surgery in your intestines or on taking out a large portion of your chest. There's also sometimes can be problems with vascularization in polymers, as the blood vessels do not fully integrate into the polymer.
So as of now, there are no existing artificial implants as competition. So our competition that we would be competing against is really just the surgery that we've mentioned. So the problems with the current procedure that we would be trying to fix is that it requires 2 surgical sites for an autograft. Obviously, with an implant, we would only need 1. There's also the high rate of failure that was mentioned, and a lot of patients will get this stricture when they have chemotherapy first. So if we want this surgery to not have to be used as a last resort, so then maybe patients could receive this procedure before chemotherapy, and they would have that lower risk of failure and reduced chance of stricture. And then obviously, since you're doing an autograft, you can't remove a lot of tissue, because the more tissue you remove from the pharynx, the more you have to remove from the pectoral muscles for the autograft. So if you can't remove as much tissue as you might need to, then there's always the risk of the tumor regrowing. So ideally, our implantable pharynx would be able to open up the possibility of surgery to a broader group of people, possibly those that don't have stage 4 throat cancer and maybe even patients that are suffering from dysphagia or something that does not cause a tumor. And we would be able to reduce the amount of surgical sites, reduce the risk of failure, and therefore increase the survival rate.